the situation, you have to sort of look at the broad picture of stroke care right now. We have really good treatments with TPA and now endovascular therapy. So if we get at patients fast enough, we can cure or reverse the damage or certainly improve the outcome in most of them. So the issue is getting patients treated faster and getting them to the right hospital, particularly with the endovascular therapy. So if mobile stroke units do that, they will substantially reduce disability. And if they substantially reduce disability, then of course costs are reduced. So then we have to go, the steps involved in translating something that works in terms of improving outcome to be widely applied requires that they get reimbursed, insurance pays for it, and all the rest. So those are all the steps we are addressing in our trial. So the answer to your question is, I don't know. That's why we're doing a randomized trial. I know that we can speed treatment. I know that that outcomes will probably be better. The question is how much better, and is it worth the cost involved in it? Of course, the study is ongoing, so there are several studies in the literature already from Germany. We were not the first to do this. We're the first in the United States to do it. But others in Germany have done it, and they've clearly shown that you can move treatment into the first hour after symptom onset. So the problem is that, as you know, with strokes, we have to distinguish between an ischemic stroke and a hemorrhagic stroke, which requires brain imaging. You have to diagnose the condition, and is there a large artery occlusion or not? All of that takes time in the emergency department, usually about an hour. It takes, on average, from the time someone gets to the emergency room to the time they get treated. So we save by moving the treatment into the pre-hospital arena, we save that whole door to needle time. So we're saving anywhere from 30 to 60 minutes of time. And so far in our pilot data, about a third of the patients that we treat, we're treating in that first hour after symptoms start, which you can't do in the emergency room. And then another third, we're treating between 60 and 80 minutes, which also is rarely accomplished in the emergency room. So we're definitely moving the needle of treatment faster with TPA. And with endovascular therapy, before someone goes up to the endovascular suite to have their clot extracted, they usually get TPA treated first. They have to have a CT angio. The endovascular team has to be alerted. Well, we do all of that in the pre-hospital setting, so that we are speeding endovascular therapy also. Furthermore, another important point is that in a regular ambulance, they may deliver the patient who needs a thrombectomy to a community hospital, and that patient then has to be evaluated in the community hospital and then bounced to the thrombectomy center. So first of all, there's a chance they may not even get recognized as a thrombectomy candidate, and secondly, there's the delay of the transfer. So all of that is eliminated by the mobile stroke unit also. We can tell, yeah, this is a thrombectomy patient and they need to go to the thrombectomy center directly. I think the number needed to treat, to reverse one stroke, to take somebody who has a disability and make them without any disability, you have to treat 8 patients with TPA. So if we just, if you calculate just the back of the envelope costs, if we reverse just 5 more strokes a year, that would recoup the cost of operating a mobile stroke unit in terms of the direct cost of stroke. So you figure one stroke costs $140,000 in 1999 dollars. That's the direct cost of the hospitalization and stuff like that. So if you just reverse 5 strokes and multiply 5 times 140,000 and then do that every year for 5 years, that amounts to the cost of building out a mobile stroke unit. So, it's a rough estimate, but the answer to your question is the only way we'll really know is by actually measuring the outcomes. But 5 patients a year is very doable when you realize you only have to treat 8 in order to reverse 1 stroke. Well, we treat 150 patients a year on the mobile stroke unit. So certainly if we're treating 150 patients and 1 out of every 8 is completely reversed, we should be reversing 5 more strokes a year than what we would do otherwise.
And that's a single stroke?
That's one mobile stroke unit in operation, only 1 shift a day from 8 in the morning to 6 at night. And I just have enough money to operate 1 shift a day.
Talk a little bit about how these stroke units are activated when there's...
Okay. That's a good question. Whatever we do with the mobile stroke unit has to be coordinated with the fire department or whatever EMS system exists. And we now You had asked earlier how many there are. There are now 13 mobile stroke units in the United States, and most major cities now have, or many major cities have one. We have the folks in Denver and Memphis collaborating with us, in Houston, and soon in New York and Los Angeles. They have mobile stroke units, will be joining our trial. But each place is slightly different in the way they work their arrangement with EMS, but they all do the same thing in the sense that the mobile stroke unit gets activated at the same time the fire department ambulance is activated. They arrive on scene together, evaluate the patient in parallel, and if it's somebody that can be treated on the mobile stroke unit, the patient goes on the mobile stroke unit. Otherwise, they get managed by the fire department. So it's a parallel process. When you think about it, the idea of pre-hospital, bringing the treatment to the patient is not, stroke is the most time sensitive of virtually any medical emergency, but other things are time sensitive too. Trauma. So on the battlefield, the trend battlefield injuries is to bring the hospital to the patient. As you know, the medics carry a little hospital on their back in these backpacks and treat the patient right there before they have a lot of blood loss and stuff like that. Same thing with coronary disease. It's been shown that in some patients who need angioplasty and stenting, which clearly is important in MI, if you give that patient a dose of thrombolytic in the ambulance on the way before they get PCI, that their outcomes are better. So it may well be that this is an approach that can be used for other conditions. Furthermore, if you really think about it, this is an emergency room on wheels. So if you're in a rural area or an underserved area which doesn't have healthcare resources, let's say a country that doesn't really have well-developed emergency rooms or EMS systems, you could have a mobile stroke unit with a remote physician and remote medical personnel by telemedicine, basically be a roving emergency room for that area. And then finally, in a disaster, same thing would be the case in a disaster area where your medical facilities are temporarily wiped out, and that's what we found after Hurricane Harvey down on the coast in Texas. They had no power to their clinic. So they asked us to come down and provide imaging and emergency capability for them. In general, look at the big picture of stroke treatment right now, at least with acute stroke treatment, that we really have good treatments. The issue is getting patients to call 911 and getting the right patient to the right hospital and to do it fast. And the way I look at it is that's all about technology. We live in a technological environment, and medicine has kind of been slow to use technology to improve our management. You can start with the medical record. Our electronic medical records are a joke when you think about how difficult they are and all they are to use, and getting patients and orchestrating patients to the right hospitals, and the whole system of healthcare, at least for stroke, could really benefit from technology. The mobile stroke unit is just one example of that.